My name is Karuna Bakra. My roll number is 34. Today, we will discuss about neurotransmitters in CNS. Inhibitory postsynaptic potential IPSP. When an inhibitory transmitter binds and interacts with specific receptors on postjunctional membrane, the membrane permeability to potassium or chloride ions increases. Excitatory postsynaptic potential EPSP. When an excitatory neurotransmitter binds and interacts with specific receptors on postjunctional membrane, the membrane permeability to cations increases. Inhibitory neurotransmitters are GABA, glycine, dopamine. Excitatory neurotransmitters are glutamate, aspartate. Acetylcholine, noradrenaline, serotonin mediate both inhibitory as well as excitatory effects. Manifestation of CNS depression, drowsiness, sedation, hypnosis, disorientation, confusion, unconsciousness, coma, death. CNS stimulation, excitement, euphoria, insomnia, tremors, twitching, convulsions, coma, death. Sedatives and hypnotics. Sedative is a drug that reduces excitement and calms the person. Hypnotic is a drug that produces sleep resembling normal sleep. Sleep. The phases of sleep include NREM, non-rapid eye movement sleep, and REM, rapid eye movement sleep. NREM sleep is divided into stages 0, 1, 2, 3, and 4. Normally, about 50% of sleep time is spent in stage 2. Slow wave sleep includes stages 3 and 4. REM sleep constitutes about 30% of the sleep time and lasts for 5 to 30 minutes in each cycle of sleep. Classification of sedatives and hypnotics. First, benzodiazepines. Diazepam, oxazepam, lorazepam, flurazepam, nitrazepam, temazepam, clonazepam, clobazepam, chlordiazepoxide, triazolam, midazolam, alprazolam. Second, barbiturates. Long-acting phenobarbital, methylbarbital, short-acting pentobarbital, secobarbital. Ultra-short-acting thiopentone, methotrexate. Third, non-benzodiazepine hypnotics. Zolpidem, zopiclone, zaleplon, azopiclone. 4. Melatonin receptor agonist, ramiltion. Fifth, miscellaneous. Chloral hydrate, promethazine, neuroleptics, opioids, etc. Benzodiazepines. All benzodiazepines have a benzene ring fused to a 7-membrane diazepine ring. Sites of action: midbrain, ascending reticular formation, limbic system, brainstem, etc. Mechanism of action: benzodiazepine facilitate action of GABA. They potentiate inhibitory effects of GABA. Benzodiazepines have no GABA mimetic action. Pharmacological actions and therapeutic use. First, sedation and hypnosis. Benzodiazepines decrease time required to fall asleep, sleep latency. The total sleep time is increased. They shorten all stages of NREM sleep except stage 2, which is prolonged. The duration of REM sleep is usually decreased. Benzodiazepines reduce night awakenings and produce refreshing sleep. At present, benzodiazepines are preferred to barbiturates for treatment of short-term insomnia because they have a wide therapeutic index. They cause near normal sleep, less rebound phenomena on withdrawal. They produce minimal hangover effects, headache and residual drowsiness on walking. They cause minimal respiratory depression. They are less likely to cause tolerance and dependence when used for short period. They have no enzyme inducing property, hence drug interactions are less. They have a specific benzodiazepine receptor antagonist, flumazenil, for the treatment of overdose. Long-term use of benzodiazepines for insomnia is not recommended because of tolerance, dependence, and hangover effects. But these drugs are ideal for occasional use by air travelers, shift workers, etc. Second, anticonvulsant. Diazepam, lorazepam, clonazepam, clobazepam, etc. have anticonvulsant effect. Intravenous diazepam or lorazepam is used to control life-threatening seizures in status epilepticus, tetanus, drug-induced convulsions, febrile convulsions, etc. Clonazepam is used in treatment of absence seizures. Third, diagnostic endoscopies and minor operative procedures. Intravenous benzodiazepines are used because of their sedative, amnesic, analgesic, and muscle relaxant properties. Fourth, pre-anesthetic medication and general anesthesia. These drugs are used as pre-anesthetic medication because of their sedative, amnesic, and anxiolytic effects. Hence, the patient cannot recall the perioperative events later. Intravenous diazepam, lorazepam, midazolam, etc. are combined with other CNS depressants to produce general anesthesia. Fifth, anti-anxiety, anxiolytic effect. Some of the benzodiazepines have selective anti-anxiety action at low doses. The anti-anxiolytic effect is due to their action on limbic system. Tolerance to anti-anxiety action does not develop even on chronic use. Sixth, muscle relaxant, centrally acting. They reduce skeletal muscle tone by inhibiting polysynaptic reflexes in the spinal cord. The relaxation effect of benzodiazepines is useful in spinal injuries, tetanus, cerebral palsy, and reduce spasm due to joint injury or sprain. 7. To treat alcohol withdrawal symptoms, chlordiazepam are used. 8. Conscious sedation. Benzodiazepines are usually given orally or intravenously and occasionally by rectal route in children. The rate of absorption following oral administration is variable. Absorption is erratic from intramuscular site of administration, hence rarely used. They have a large volume of distribution. They have a short duration of action on occasional use because of rapid redistribution, hence are free of residual hangover effects, even though elimination half-life is long. Benzodiazepines are metabolized in liver. Some undergo enterohepatic recycling. Some of them produce active metabolites which have long life. Hence, cumulative effects may be seen. Oxazepam is not significantly metabolized in liver. The metabolites are excreted in urine. Benzodiazepines can cross placental barrier. Adverse effects. Benzodiazepines have a wide margin of safety. They are generally well tolerated. The common side effects are drowsiness, confusion, blurred vision, amnesia, disorientation, tolerance, and drug dependence. Withdrawal after chronic use causes symptoms like tremor, insomnia, restlessness, nervousness, and loss of appetite. Use of benzodiazepines during labor may cause respiratory depression and hypotonia in the newborn. Floppy baby syndrome. In some patients, these drugs may produce paradoxical effects, that is, convulsions and anxiety. Important features of benzodiazepine. Drug diazepam, oral, IV, IM, rectal. Oral dose 5 to 10 milligrams. Rapidly absorbed from GI tract, produces active metabolites, no residual effects on occasional use due to redistribution. It is used to control convulsions but not for long term therapy of epilepsy because of rapid development of tolerance to anticonvulsant effect. It can be used rectally to control convulsions. Other points: Florazepam, oral, oral dose 15 milligrams. Useful in insomnia, causes hangover effects because of active metabolite with long half-life. Nitrazepam, oral 5 to 10 mg oral dose. Useful in insomnia, residual effects are less on occasional use. Oxazepam, oral, orally dose 15 mg. Slowly absorbed, no active metabolite, can be used in patients with liver disease, mainly used as anti-anxiety agent. Lorazepam, oral, IM, IV, 0.5 to 2 mg. Rate of GI absorption is low. No active metabolite. Anticonvulsant effect lasts longer than with diazepam because it is less lipid soluble and redistribution is low. Mainly used as anticonvulsant, anti-anxiety, and pre-anesthetic medication. Less irritant, hence thrombophlebitis is rare on IV administration. Alprazolam, oral 0.5 to 2 mg. Useful in insomnia. Produces active metabolite, high anxiety and antidepressant effects. Temazepam, oral 7.5 to 30 mg. No active metabolite, mainly used for insomnia. Triazolam, oral 0.125 to 0.25 mg. Has rapid onset of action, short acting, mainly used for insomnia, reduces sleep latency. Midazolam, IV, IM, 1 to 2.5 mg. Has rapid onset of action, short acting. Used as pre-anesthetic medication, IV. General anesthesia when combined with other CNS depressant in status epilepticus when not responding to other drugs. Claudia's epoxide, oral IM IV 50 to 100 mg. Slow oral absorption, produces active metabolite, long acting, used in alcohol withdrawal and anxiety. Benzodiazepine antagonist, flumazenil. Flumazenil competitively reverses the effects of both benzodiazepine agonists, CNS depression, and benzodiazepine inverse agonists, CNS stimulation. Flumazenil is not used orally because of its high first pass metabolism. It is given by IV route and has rapid onset of action. Flumazenil is used in treatment of benzodiazepines overdose and to reverse the sedative effect of benzodiazepine during general anesthesia. It can also be used to reverse hypnotic effect of zolpidem, zaleplon, and isopicolone. Adverse effects include confusion, dizziness, and nausea. It may precipitate withdrawal symptoms, anxiety, and convulsions in dependent subjects. Barbiturates. All barbiturates are derivatives of barbituric acid. They are non selective CNS depressants and act at many sites, ascending reticular activating system, ERAS being the main site. Mechanism of action. Barbiturates have GABA facilitatory action. They potentiate inhibitory effects of GABA. At high concentrations, barbiturates have GABA mimetic effect. Pharmacological actions and uses. First, sedation and hypnosis. Barbiturates were used in the treatment of insomnia. They decrease sleep latency, duration of REM sleep, stage 3 and 4 of NREM sleep. They caused marked alteration of sleep architecture. At present, barbiturates are not recommended because they have a low therapeutic index, they cause rebound increase in REM sleep on stoppage of therapy, they cause marked respiratory depression, they produce marked hangover effects, they cause high degree of tolerance and drug dependence. They are potent enzyme inducers and cause many drug interactions. They have no specific antidote. Second, general anesthesia. Short, ultra short acting barbiturates may be used for induction of general anesthesia. Third, anticonvulsant. Phenobarbital has anticonvulsant effect and is used in the treatment of status epilepticus and generalized tonic-clonic seizures. Fourth, neonatal jaundice of non-hemolytic type. Phenobarbital may be used to reduce serum bilirubin levels. It induces glucuronil transferase enzyme and hastens the metabolism of bilirubin. Adverse effects. First, the common side effects are drowsiness, confusion, headache, ataxia, hypotension, and respiratory depression. Second, hypersensitivity reactions like skin rashes, itching, and swelling of face may occur. Third, tolerance develops to their sedative and hypnotic actions on repeated use. Fourth, physical and psychological dependence develops on repeated use. Fifth, prolonged use of phenobarbital may cause megaloblastic anemia by interfering with absorption of folic acid from gut. Sixth, they may precipitate attacks of acute intermittent porphyria by inducing ALA synthase that catalyzes the production of porphyrins. Hence, barbiturates are contraindicated in porphyria. 7. Acute barbiturate poisoning. The signs and symptoms are drowsiness, restlessness, hallucination, hypotension, respiratory depression, convulsions, coma, and death. Treatment of acute barbiturate poisoning: maintain airway, breathing, and circulation, maintain electrolyte balance. Gastric lavage: after stomach wash, administer activated charcoal that may enhance the elimination of phenobarbital. Endotracheal intubation is performed before gastric lavage to protect the airway in unconscious patients. Alkaline diuresis. There is no specific antidote for barbiturates. Main treatment is alkaline diuresis. Intravenous NaHCO3 alkalizes urine. Barbiturates are weakly acidic drugs. In alkaline urine, barbiturates exist in ionized form, so they are not reabsorbed while passing through renal tubules and are rapidly excreted in urine. Hemodialysis is employed in several cases. Drug interactions. Barbiturates are potent inducers of hepatic microsomal enzymes and reduce the effectiveness of co-administered drugs. Example: oral contraceptives, oral anticoagulants, oral hypoglycemics, etc. Non-benzodiazepine hypnotics. They include zolpidem, zopiclone, Zepplon, and azopiclone. They have less potential for abuse than benzodiazepines. They have less anti-anxiety, anticonvulsant, and muscle relaxant effects than benzodiazepines. Effect on REM sleep is less as compared to benzodiazepines. Zolpidem mainly produces hypnotic effect, decreases sleep latency, and increases duration of sleep in insomnia. It produces near normal sleep like benzodiazepines with minimal alteration in REM sleep, causes minimal hangover effects and rebound insomnia, less likely to produce tolerance and drug dependence, lacks anticonvulsant, anti-anxiety and muscle relaxant effects. It is given orally, well absorbed, metabolized in liver and excreted in urine. It has a short duration of action and is used for short-term treatment of insomnia. The actions of zolpidem are antagonized by flumazenil. The common side effects are headache, confusion, nausea, and vomiting. Mechanism of action: zolpidem, zopiclone, zeplon, ezopiclone, non-benzodiazepine hypnotics bind selectively to be benzodiazepine binding site on GABA A receptor, facilitate GABA mediated neural inhibition, CNS depression. Zopiclone. Zopiclone is orally effective and is used for short term treatment of insomnia. It produces near normal sleep like benzodiazepines. The side effects are headache, drowsiness, GI disturbances, and metallic taste. Zaleplon. It is useful in sleep onset insomnia. It is the shortest acting on non-benzodiazepine hypnotic. Esopiclone. It is used orally for short and long-term treatment of insomnia. Melatonin. It is the hormone secreted by the pineal gland involved in main of sleep-wake cycle and circadian rhythm. Rameltion. A melatonin receptor, MT1 and MT2 agonist can use orally for the treatment of sleep onset insomnia. It reduces sleep latency and prolongs total duration of sleep. There is no rebound insomnia on withdrawal. Does not cause tolerance on chronic use. The important adverse effects are fatigue and dizziness.